Bismillah ar-Rahman ar-Rahim. I am Dr. Mervet Abu Jabal, Professor of Internal Medicine and Rheumatology in Shams University. Welcome to the presentation of this undergraduate lecture in rheumatology. Our topic today will be osteoarthritis. I will share my screen now. As I said, my topic today is osteoarthritis. Our intended learning outcome are, by the end of this lecture, students should be able to define osteoarthritis, understand risk factors of the disease and its pathogenesis in brief, classify the disease as primary and secondary, learn the clinical presentation of osteoarthritis, and lastly, diagnose and select suitable non-pharmacological and pharmacological therapy or advise surgery for the patient. Now, what is osteoarthritis? Osteoarthritis is joint disease characterized by pathology involving the whole joint, including cartilage degradation, bone remodeling, osteophyte formation, and synovial inflammation, leading to pain, stiffness, swelling, and loss of joint function. Actually, the pathologic process in osteoarthritis is mainly driven by cartilage, but participation of subchondral bone and synovial membrane come secondary to cartilage degradation, as you will see. Now, what about the prevalence of osteoarthritis? Osteoarthritis is the most common form of arthritis and a leading cause of pain and disability worldwide. The most frequently joints to be affected: hip, knee, and hand. The lifetime risk of having a total hip or knee replacement for osteoarthritis in someone aged 50 years is about 11% in women and 8% in men. Now, what about osteoarthritis' impact on functional capacity? In 2012, the World Health Organization reported that worldwide, an estimated 10% of men and 18% of women over 60 years of age have symptomatic osteoarthritis. Approximately 80% of those having osteoarthritis will have movement limitations, and 25% are unable to perform leisure activities of daily living. The prevalence of diseases such as osteoarthritis will increase in the future. Indeed, by the year 2050, the World Health Organization estimates that 130 million people will have osteoarthritis and 40 million will be severely disabled by osteoarthritis. Now, who gets osteoarthritis? This means what are risk factors for development of osteoarthritis? First of all, osteoarthritis is the disease of old age. So, old age is an important risk factor for development of osteoarthritis. Obesity is another risk factor for developing osteoarthritis, especially osteoarthritis of lower limb joints, which are weight-bearing joints. However, osteoarthritis is higher or occur with higher prevalence in obese person, even in men. Guess why? Gender is another risk factor for developing osteoarthritis. Osteoarthritis is more prevalent, more severe, with more joint affection in female compared to males. Family history and genetic factor are also risk factor for development of osteoarthritis. Even more, the same type of osteoarthritis run in the same family. Metabolic diseases like ochronosis, hemochromatosis, and recently metabolic disease or inflammatory disease are risk factors for development of osteoarthritis, especially knee osteoarthritis. Trauma, occupation, and sport, where there is repetitive activities, can result in bone and joint injury and predispose to occurrence of osteoarthritis. Lastly, congenital joint disease like congenital femoral dysplasia at the hip or internal derangement of the knee can predispose to osteoarthritis. Regarding the pathogenesis of osteoarthritis, at early stages of osteoarthritis, the condition started by occurrence of insult, which result in cartilage injury. As you know, the main cells in the cartilage are chondrocytes. Chondrocytes are metabolically active cells which are responsible for synthesis and deposition of cartilage matrix. They deposit cartilage matrix around them, forming their own microenvironment and become trapped inside this microenvironment, cannot travel or migrate in different parts of the cartilage. These chondrocytes, in attempt to repair the injured cartilage, start to secrete growth factors. So early in the disease, growth factor concentration increase in cartilage matrix, but imbalance occur between this secretion of these growth factors and other degradation factors like metalloproteinases and collagenesis. So the net result is occurrence of imbalance in favor of degradation, with degradation of type 2 collagen, which is the main collagen of the cartilage, and proteoglycans, especially aggrecan, which are very important constituent of the cartilage. They form aggregate with osmotic property, which retain water inside the cartilage, rendering it resistant and can withstand compressive forces. Now, after degradation of type 2 collagen and degradation of proteoglycans, especially aggrecan, the cartilage become weak, and the formation of cartilage matrix is inadequate, which become weak and cannot withstand compressive forces. This results in vicious circle with more cartilage degradation, more cartilage injury, with imbalance resulting continuous degradation or progressive degradation. At the same time, pathology occurs at the chondrocyte level. They undergo apoptosis. This increased apoptosis of chondrocytes in osteoarthritis, together with reaction from subchondral bone and synoviocytes. How can this occur? Degradation of the cartilage results in release of degradation debris into synovial fluid. Synovial fluid debris engulfed by macrophages in synovial membrane. These macrophages react by production of pro-inflammatory cytokines and metalloproteinases. Metalloproteinases again result in more degradation of the cartilage, more production of cartilage debris to be secreted into synovial cavity to be engulfed by synovial macrophages. At the same time, pro-inflammatory cytokines produced by synoviocytes or synovial macrophages result in induction or stimulation of inflammation of synovial membrane, but usually this is mild, patchy, chronic synovitis. And again, another vicious circle is produced with cartilage degradation, synovial inflammation, and so on. Synovial inflammation happens in early and also acute phases of osteoarthritis. Now, what is the role of subchondral bone? Subchondral bone also is abnormal in osteoarthritis. They secrete factors to reach deep zone of chondrocytes, or chondrocytes at deep zone of the cartilage, disturbing their function. In or at subchondral bone, there is osteosclerosis, subchondral cyst formation at region. Fibrocartilage is produced at joint margin, which undergo endochondral ossification to form osteophytes. So finally, despite the fact that osteoarthritis as pathologic process is mainly cartilage driven, but participation, as I said, of subchondral bone and synovial membrane are very important in development or pathogenesis that result in cartilage degradation. Finally, the entire joint is affected with progressive degradation of ligaments, capsule, periarticular muscle, and even periarticular nerves. This will be transmitted to cartilage pathology with occurrence of cartilage destruction and loss, occurrence of subchondral bone adhesion, subchondral bone cyst formation and sclerosis, occurrence of synovial inflammation, which is usually mild, together with surrounding ligament and muscle weakening and contraction. As you see, comparison between normal joint grossly and the abnormal joint affected by osteoarthritis, there is narrow, even loss of joint space with direct friction between articular bone. Subchondral bone become abnormal and weak with subchondral sclerosis and cyst formation. At joint margin, new bone formation in the form of osteophytes will be present. What about the synovial fluid? Effusion is not a characteristic feature of occurrence of osteoarthritis, but it may be present chronically without inflammation, known as cold effusion, or may be present during time of flare of synovitis. This synovial fluid, in case of osteoarthritis, is usually non-inflammatory. Now, what are features of non-inflammatory synovial fluid? This pathogenetic process, followed by joint pathology, will be translated or reflected to produce clinical picture of osteoarthritis. Now, what are symptoms and signs of osteoarthritis? The major symptom of osteoarthritis is occurrence of joint pain, arthralgia. Usually, joint pain in osteoarthritis is insidious over months or years, usually variable or intermittent. It is mechanical in nature, occur as usage pain with movement of the joint, and usually relieved by rest at early stages of the disease, associated with morning stiffness less than half an hour or 30 minutes, together with brief stiffness 5 to 10 minutes after period of rest, known as gelling. Usually one or few joints are affected. Regarding signs, there is restricted movement of the affected joint due to capsular thickening and blocking by osteophytes. There may be crepitus, which may be palpable or audible during movement of the affected joint. Tender bony swelling are felt at joint margins. Deformity with or without instability of the affected joint can occur, especially in long-standing osteoarthritis. Also, long-standing osteoarthritis, muscle weakness and wasting, especially affecting muscles surrounding the affected joint. Clinical signs of synovitis are usually mild or absent. A joint effusion can be detected by clinical examination. Now, regarding classification of osteoarthritis, it can be classified according to the underlying possible etiology. So there is primary and secondary osteoarthritis. In primary osteoarthritis, no underlying disease process. Here, irritability and aging are the most important predisposing factors. But in secondary osteoarthritis, usually it's this previous joint disease which results in previous joint damage. This joint disease may be congenital, metabolic, inflammatory, or traumatic. Also, osteoarthritis can be classified according to the joint affected or the area affected by osteoarthritis. For example, there is hand nodal osteoarthritis, there is hip osteoarthritis, knee osteoarthritis, spine osteoarthritis or axial osteoarthritis, and lastly, erosive osteoarthritis. Regarding hand nodal osteoarthritis, it usually affecting middle-aged female, occur mainly in proximal and distal interphalangeal joints and first carbo-metacarpal joint, and usually associated with hybrid nodes and Bouchard nodes, which are polynodules, can be detected clinically at dorsum of proximal and distal interphalangeal joints. As I said, hand nodal osteoarthritis is markedly or greatly related to age and heritability or genetic factors. The second type is axial osteoarthritis. It mainly affects cervical region and lumbosacral region or lumbar region. known as cervical or lumbar spondylosis. This may result in compression of nerve root with radicular pain in upper and lower limbs. Hip osteoarthritis can occur, especially its large weight-bearing joint in lower limb. This resulting in anterior groin pain or even anterolateral pain due to trochanteric bursitis. The first movement to be affected in hip osteoarthritis or to be restricted in hip osteoarthritis is the internal rotation. Knee osteoarthritis is very common. It affects the medial femorotibial compartment and the patellofemoral joint, usually associated with anserine bursitis or associated with medial collateral ligament injury. By the way, the first metatarsophlangeal joint is very commonly to be affected by osteoarthritic process. Now, what about erosive osteoarthritis? Erosive osteoarthritis is not that common. It occurs only in 5 to 15% of hand nodal osteoarthritis. To diagnose erosive osteoarthritis, the first step is to diagnose presence of hand osteoarthritis using ACR classification criteria, as you will see. The second step is to detect presence of erosions in at least 2 interphalangeal joints of the hand. One of them must be distal interphalangeal joint. These erosions should be subchondral erosions to be differentiated from marginal erosions that occur in rheumatoid arthritis. At the same time, this patient usually has normal acute phase reactant or near normal ESR and C-reactive protein. To complete diagnosis of erosive osteoarthritis of the hand, there must be no personal or family history of psoriatic arthritis. There is no history or evidence of gout or pseudo gout affecting hand. Also, there must be negative serology for rheumatoid arthritis, especially rheumatoid factor and anti-CP antibody. These are hyperdenose detected clinically over the distal interphalangeal joint. They are bony hard nodules in osteoarthritic patient. These are hybriden nodes and Bouchard nodes, hybrid nodes on dorsum of distal interphalangeal joint, Bouchard nodes on dorsum of proximal interphalangeal joints in hand nodal osteoarthritis. These are lower limb deformity occurring in osteoarthritic patient due to subluxation of metatarsophalangeal, the first metatarsophalangeal joint. There is hallux valgus deformity of the big toe, together with cock-up deformity here, with flexion of proximal interphalangeal joint and extension of distal interphalangeal joint of this toe, with flexion deformity of rest of the toe. There may be overriding toes. Regarding knee deformity in osteoarthritis, the classic and most common deformity is occurrence of geniovarus deformity due to affection of medial compartment of femorotibial joint, but also geniovalgus deformity can occur in some cases. Now, how can you diagnose joint osteoarthritis? ACR developed classification criteria for diagnosis of hand osteoarthritis. They are mainly clinical criteria regarding hand osteoarthritis. Regarding hip osteoarthritis, they developed clinical and radiographic criteria to diagnose hip osteoarthritis. For knee osteoarthritis, there are 2 sets of criteria. One of them are clinical, and the other is post-clinical and radiographic, which help diagnosis of knee osteoarthritis. We will apply this classification criteria to diagnose our patient in clinical round. Please have a look. In general, diagnosis of osteoarthritis can be performed on clinical ground, but in certain situations, especially when there is a typical presentation, we may require investigations. In general, routine laboratory workup or investigations are completely normal. Acute phase reactant are normal or near normal in erosive osteoarthritis. All serology, rheumatoid factor, anti-CP, antibody, ANA, anti-DNA, antibodies are all negative in case of osteoarthritis, especially primary osteoarthritis. Globally, for each joint, diagnosis of osteoarthritis can be made on basis of presence of joint mechanical pain or usage pain, presence of brief stiffness of less than 30 minutes. Usually the patient is over 50 years, together with presence of X-ray findings. These are presence of joint space narrowing or osteophytes on plain radiograph, which is the current standard imaging modality in clinical practice for diagnosing and monitoring osteoarthritis if indicated. This means that imaging is not indicated in all cases of osteoarthritis to diagnose or to monitor the progression of disease, according to EULAR recommendation for use of imaging in the clinical management of peripheral joint osteoarthritis, released in 2017. According to these recommendations, imaging is not required to make the diagnosis in patients with typical presentation of osteoarthritis. Even more, in a typical presentation, imaging is recommended just to help confirm diagnosis of osteoarthritis and or make alternative or additional diagnosis. What about during follow-up of osteoarthritis? Routine imaging in osteoarthritis follow-up is not recommended. However, imaging is recommended if, number one, if there is unexpected rapid progression of symptoms, or number two, if there is changing clinical characteristics, why we must do imaging to determine if this relate to osteoarthritis severity or there is an additional diagnosis. Lastly, when imaging is indicated in cases of osteoarthritis, whether at diagnosis or during follow-up, conventional or clean radiography is first choice. For better assessment of soft tissue, ask for ultrasound or MRI. For better assessment of bone, ask for CT or MRI. Lastly, imaging is required in case of intra-articular injection to guide injection, seeking for accuracy of this injection in certain situations. When the joint is deep or difficult to access, like in hip joint, or when there is degree of deformity or obesity, which makes this intra-articular injection difficult when performed blindly. So imaging may be required. Now, what is meant by a typical presentation of osteoarthritis? Seeing to answer in face-to-face session. Now, what are radiographic findings in osteoarthritis of hand, knee, hip, and spine? Here, in osteoarthritis of the knee, as you see, there is non-uniform joint space narrowing occurring mainly at the medial tibiofemoral compartment. There is polyosteophytes at joint margin. There is subchondral sclerosis at articular bone. Here in hand osteoarthritis, the main joints to be affected are distal interphalangeal joints, proximal interphalangeal joints, and first carbometacarpal joint causes squaring of the hand here. Both distal and proximal interphalangeal joints show joint space narrowing and loss of joint space in some of the joints, together with subchondral erosions, giving the joint sawtooth appearance and sometimes gull-wing appearance, which is characteristic radiographic feature of osteoarthritis in hand. This image shows osteoarthritis of hip joint with narrow joint space, subchondral bone cyst, subchondral sclerosis in the joint. This is osteoarthritis or spondylosis of lumbar spine with characteristic kissing osteophytes. This plain X-ray of the knee show radiographic progression of osteoarthritis with progressive narrowing of joint space, especially at the medial compartment, and osteophyte formation. Despite this, no periarticular osteopenia. However, instead there is periarticular or subchondral bone sclerosis, but no cyst formation here. Now, why and how can you help a patient with osteoarthritis? The goal of treatment of osteoarthritis is to relieve pain, swelling, and inflammation, is to inhibit and delay progression of joint damage, and finally, to prevent severe disability and improve quality of life. The most recent update in management of osteoarthritis is released in 2019 by ECR Arthritis Foundation. They provided guidelines for management of osteoarthritis of hand, hip, and knee. According to these guidelines, they state that a comprehensive plan for management of osteoarthritis in an individual patient may include educational, behavioral, psychological, and physical interventions, as well as topical, oral, and intra-articular medications. Starting by non-pharmacological interventions, in short, they include management, self-management education programs, cognitive behavioral therapy, exercise, whether strengthening or non-strengthening exercise, whether land-based exercise or aquatic exercise, especially in hip and knee osteoarthritis. Also, non-pharmacological therapy include manual therapy, including massaging, weight management, and also cold or heat application. Regarding weight management, especially in knee and hip osteoarthritis, this should be applied in overweight and obese population with body mass index equal or more than 25 kilogram per square millimeter, or equal or more than 30 kilogram per square millimeter. Here, minimum weight loss target of 5 to 7.5% of body weight is recommended. Also, braces, orthotics, or joint orthosis, tapping, footwear, and canes are important components of non-pharmacologic intervention in cases of osteoarthritis. Here, these are the different modalities of physical, psychological, or non-pharmacologic modalities in treatment of hand, knee, and hip osteoarthritis. These are the different pharmacologic modalities or options in treatment of hand, knee, and hip osteoarthritis. As you see, some of them are strongly recommended, like oral non-steroidal anti-inflammatory, topical non-steroidal anti-inflammatory. Oral non-steroidal anti-inflammatory are strongly recommended in the three types of osteoarthritis: hand, knee, and hip. However, topical non-steroidal anti-inflammatory are strongly recommended in knee osteoarthritis, but conditionally recommended in hand osteoarthritis. Intra-articular steroid injection of the joint is guided by imaging in case of hip is strongly recommended in case of knee and hip osteoarthritis. Acetaminophen, duloxetine are conditionally recommended in the three types of osteoarthritis. Also, topical capsaicin conditionally recommended in knee osteoarthritis, chondroitin only in hand osteoarthritis. I don't want to mention tramadol. To my surprise, tramadol is conditionally recommended in the three forms of osteoarthritis. Personally, I don't recommend tramadol for management of osteoarthritis. These are the non-pharmacological and pharmacological options recommended against either strongly or conditionally by the ECR 2019 recommendations for management of osteoarthritis. Please have a look. All these will be revised in our clinical round and applied on our patient with osteoarthritis. If we compare this 2019 ECR recommendation for management of osteoarthritis of the hand specifically that was released by Euler in 2018, they are the same. But regarding the 2016 panel recommendation for or guidelines for management of hip and knee osteoarthritis, the situation is completely different. For example, non-steroidal anti-inflammatory is still recommended. It was recommended in 2016, still recommended by ACR, whether oral or topical. Capsaicin gel still recommended by ACR 2019 guidelines for knee osteoarthritis. Intra-articular steroid is strongly recommended for knee osteoarthritis, both in 2016 and in 2019. Deluxetine is still recommended for knee osteoarthritis. Paracetamol is conditionally recommended for knee osteoarthritis. As I said, I don't want to mention tramadol. However, other therapeutic modalities or options that were recommended by Bandler group in 2016, like chondroitin, glucosamine, whether alone or with combined with chondroitin, avocado soya bean, hyaluronic acid, whether oral or intra-articular injection, intra-articular injection of PRP, intra-articular injection of stem cells, supplement, dietary supplement like omega-3 and fish oil or vitamin E, all are recommended against by 2019 ACR recommendation for management of osteoarthritis. Now, during follow-up of your patient, how can you follow up the patient at first? You must follow the patient by assessment of two components, the pain and the function. Regarding pain can be assessed by use of visual analog scale on a scale from 0 to 10. Regarding the function, especially of in case of hip and knee osteoarthritis, you can use tests recommended by Osteoarthritis Research Society International Advisory Group. They recommended minimal core set of performance-based tests for hip and knee osteoarthritis. These tests are 40-meter fast-paced walk test, stair climbing test, and the 30-second chair stand test. During follow-up of your patient, what is the timing and the need for referral to an orthopedic surgeon? C, to answer in face-to-face session. Now you can take home message. Osteoarthritis is the most common form of chronic arthritis and is a leading cause of pain and disability worldwide. It can affect axial or peripheral joints. It may be mono, oligo, or polyarticular joint disease. It is diagnosed on clinical ground and managed in primary care by general practitioners, except if there are atypical presentations. This means if there are red flags against diagnosis of osteoarthritis. Now, be ready for comprehensive discussion in face-to-face session. Thank you for your time. See you soon in face-to-face session to answer your questions. Thank you. I will end my meeting now.